Wash your hands, introduce yourself. Hi, my name is Christina. I'm the PA student. I'll be doing your examination today of the thorax and lungs. I begin by observing the respiration. I'm looking at the rate, the rhythm, the effort, the depth. I'm going to assess the respiratory rate. How the patient breathe in and out normally through their lungs. Okay, 9 times 2 is 18 breaths per minute. Normal range is 14 to 20. Good. I'm also assessing the neck. I'm looking for use of any accessory muscles, any retractions. I'm assessing the sternal notch and the trachea, making sure that it's midline and there's no deviations. I'm assessing the mouth and the fingernails and toenails. They should be pink. I'm looking for any cyanosis, any clubbing. I'm also checking for capillary refill, which should be 2 to 3 seconds. In the upper and the lower extremities as well. As I go to the back from the lateral side, I'm assessing the AP diameter to make sure it's not enlarged or increased, such as in COPD or barrel chest. When I examine the posterior thorax, I ask the patient to please cross your arms in the front, like this. I inspect. I'm looking for symmetrical movement of the thoracic cavity. I'm looking for any abnormalities, any scars or lesions. I'm going to palpate, feeling for any tenderness, any depressions. I'm going to assess for tactile firmness. Please say 99 each time you feel it with my hands.
99, 99, 99, 99, 99.
And I'm feeling for the vibrations. You can do it one of two ways, either with the palm of your hands or the ulnar surface. This way would be correct as well. Then I check for thoracic expansion. I place my thumbs at what level? T10, good. Which you can look at the scapulas, the T7, and then just count 3 down. Take a big breath in and out through your mouth, please. And I look for symmetrical rise and movement of my hands and thumbs. Then I'm going to percuss in the ladder pattern. You're going to do it bilaterally. And throughout the lungs, what should you hear? What sound? Resonance, good. Then you do the sides. Then I'm going to check the diaphragmatic excursion, the level of the diaphragm as it raises. I drew a little diagram on the boards that helps a little bit depicting this. What I'm going to ask the patient to do is take a big breath in and out through their mouth and hold it out. Big breath in and out and hold out. You're going to start about halfway down the lung, listening for resonance to dullness. Is it okay if I make a mark on your back?
Stop drawing the grid.
You're going to draw a small line on the area after they've exhaled, where it changes from resonance to dullness. Then you're going to ask them to take a big breath in and hold. Again, starting about mid-lung. Listening from resonance to dullness. I'm going to make that second mark. So the lower mark is when they inhale because the diaphragm, it's air, the lungs are filled with air and the diaphragm has lowered. And then when they exhale, that's going to be your top mark. And then you're going to measure the distance between the two. Diaphragmatic excursion should be how many centimeters? 5 to 6, good. Then you auscultate, again using the ladder pattern with the diaphragm of your stethoscope. Take a big breath in and out through your mouth each time you feel my stethoscope, please. Make sure the patient does it with the mouth open.
out. Getting there.
You're listening to the breath for the rate, the rhythm, the intensity, the duration, the pitch. Different things you're listening for are wheezing, bronchi, crackles, rales. If you do hear an area with an adventitious noise, you're going to proceed with one of the 3 special tests. What's the first test? Bronchophony. So let's say I heard an abnormal sound up here. Have the patient say 99.
99.
And you listen for transmission of the sound through the stethoscope to see if it's increased or decreased. What's one of the other special tests you can do? Egophony. Ask the patient to say E.
E.
And you should hear E. If it changes to A, that means that there's consolidation. And that would be a positive egophony test. And what's the last special test? Whisper pectoriloquy. Have the patient whisper 1, 2, 3.
What did he say?
One more time.
Who's that?
Whisper 1, 2, 3, please.
Paul, can I whisper in your ear, please?
What?
Okay, and you should hear it slightly muffled. Again, listening for any increase in the intensity. Then you inspect the anterior thorax. Ask the patient to lie back, please.
Be careful with your hands.
You always begin with inspection. I'm watching the rise and the fall of the chest. I'm looking for any abnormalities, any lesions, any scars. Then you proceed with palpating. You're feeling for any abnormalities, any bony deformities. Then you're going to check for thoracic expansion, the same thing. You're going to place both fingers at the costal margin, take a big breath in and out through your mouth. And you're going to look for symmetrical movement of the hands. You're going to check for tactile fremitus, say 99 each time you feel the ulnar surface of my hand.
99.
Again.
99. 99. 99. 99.
Good. You could do it that way, or another technique would be by using the ball of your hand. Go ahead, 99.
99.
Again.
99. 99. 99. 99.
Either way would be correct. And then you percuss. Again, you're going to start up. Where's the apex of the lung?
Above it.
Above the clavicle. So you're going to use the ladder pattern. And you should hear resonance. Then you're going to auscultate the same areas. Every time you feel my stethoscope, please take a big breath in and out through your mouth. Using the diaphragm, again starting above the clavicle. Noting the rate, rhythm, intensity, pitch, listening for any adventitious sounds such as wheezing, crackles, rales, bronchi. If you did hear an adventitious sound, you would do the special test just in the area where you heard it. You wouldn't have to go through all the fields. So let's say I heard wheezing up here, then I would go ahead and proceed with either egophony, bronchophony, or pectoriloquy in the area right up here where I heard the sound. Any questions?